Our disclosures are that Drs. Gaffari and Finks receive salary support as the director and co-director of the Michigan Bariatric Surgery Collaborative. The U.S. population has 75% of adult Americans that are considered overweight, obese, and extremely obese. Additionally, the U.S. population is aging at a rapid rate with an expected 55 million persons over the age of 65 by the year 2020. So therefore, of those over the age of 65, 30% are obese. 35% are obese. As the aging population continues to rise, so will the proportion that are obese. Bariatric surgery remains the most effective treatment for morbid obesity. Increasing improvements in safety are associated with decreased rates in complications for postoperative patients, which has led to an increased spectrum of patients being treated with these procedures. While they are traditionally considered very safe procedures for most patients, the safety and efficacy of bariatric surgery in older patients are unknown. So therefore, we sought to evaluate the safety and efficacy in this population. To evaluate the safety and efficacy, we utilized data from the Michigan Bariatric Surgery Collaborative, which is a prospective clinical registry that's a regional voluntary consortium of hospitals and surgeons that practice bariatric surgery in the state of Michigan. It is supported by the Blue Cross Blue Shield of Michigan and includes a large number of patients, and our sample is from 2006 to 2016. In total, we had over 20,000 patients undergoing primary procedures, including Roux-en-Y gastric bypass, sleeve gastrectomy, and laparoscopic adjustable gastric band placement. As there are no current standards for when performing bariatric surgery is off limits in the older population, we sought to capture typical practice of those providers in the MBSC and also in the SAGES community. We polled practicing surgeons both in the state of Michigan and the Foregut Surgery Collaborative, and about 71% of those who responded said they don't have a firm cutoff for when they offer bariatric surgery or not. However, those who did respond tended to say that their cutoff was about 70 at the time at which they would no longer consider offering a bariatric procedure to a patient. For our outcomes, we evaluated each of these procedures for complications, including any complications postoperatively, serious complications that are considered life-threatening, surgical complications, leak, perforations, hemorrhage, etc., and medical complications, including cardiac, pulmonary, renal, and venous thromboembolism. We then compared the rate of excess percentage weight loss at 1 year and the rates of comorbidity resolution also at 1 year, and this was determined by the discontinuation of medical therapy for chronic conditions, including diabetes, sleep apnea, hyperlipidemia, and hypertension. Based on our social media survey, we divided our patients into 3 categories: less than the age of 45, 45 to 69, and those over the age of 70. As you can see, we had approximately 600 patients in our category over the age of 70. There were an increasing number of males in the older population, as well as those that were less likely to smoke, had smaller BMIs before their procedures, and had a larger number of comorbidities, with approximately 6 each patient. Specifically, these older patients had higher rates of cardiovascular disease, diabetes, and renal failure before their operations. Here we present the rates at which these procedures were performed in each of the populations. As you can see, 28% of these patients over the age of 70 underwent a Roux-en-Y gastric bypass, which is substantially lower than the other cohorts. The rates for lap band were higher than the younger cohorts, and the rates of sleeve gastrectomy were about on par. As this data reflects a 10-year sequence, we do have a high number of lap band procedures performed. However, because this is an uncommon procedure performed today, we've decided to move forward with our analysis with just the Roux-en-Y gastric bypass and sleeve gastrectomy. First, we analyze the safety of Roux-en-Y gastric bypass. Here we compare the rates of these complications as we described before. This demonstrates that the safety profile is fairly consistent for the older patients compared to the younger patients. The only statistically significant finding was an increased rate of any complications at 15% compared to 11% for younger groups. We compared to the middle range group of 45 to 69 for each of these findings. When we look at sleeve gastrectomy, we once again see a largely similar profile. The only difference in this group was a slightly increased rate of serious complications that was statistically significant. Once again, 3.4 versus 1.6 in the slightly younger population. When comparing mean excess weight loss, we determine this both in an unadjusted and adjusted form. Here we present the unadjusted numbers. These did not account for the patient's age or comorbidities, and we see that the older patients were about on par with the younger patients as well. So patients over the age of 70 still had a significant effect from their procedures, with 66% for Roux-en-Y gastric bypass and 56% for sleeve gastrectomy. When we adjust for patient comorbidity, the results are more substantial. So we see that the patients over 70, if they had the similar health profile of the younger patients, actually had a higher weight loss, which is consistent with our finding when we look at the raw numbers, but the adjusted numbers show that it's a little bit higher. Turning now to comorbidity resolution, we wanted to see how effective these procedures were for the older populations in actually relieving them of some of their medical burden. So for patients undergoing Roux-en-Y gastric bypass with diabetes-related medications, 83% of those on oral medications and 63% of those taking insulin were able to stop their therapies. This was similar to the younger groups and was only statistically significantly increased compared to the middle group for the oral medications. We see a similar but less substantial pattern for sleep apnea. Only about 50% of older patients were liberated from their CPAP treatment. And for hypertension and hyperlipidemia, once again, slightly lower rates of discontinuation, but still very substantial compared to other procedures. We find similar patterns, although slightly less substantial relief of medical therapies for sleeve gastrectomy. So patients in the older groups had 65% and 50% of discontinuation of diabetes-related medications, only 39% for sleep apnea treatment, and about 30% and 33% for hypertension and hyperlipidemia. In summary, despite significant increases in preoperative multimorbidity, patients over the age of 70 benefit from comparable percentage excess weight loss and largely similar rates of comorbidity resolution as younger populations. Older patients over the age of 70 did have higher rates of postoperative complications after Roux-en-Y gastric bypass and had a higher rate of serious complications after sleeve gastrectomy, but their postoperative complication profiles were largely similar otherwise. These findings suggest that bariatric surgery is safe in older adults and provides similar overall health benefits to those patients in younger cohorts. Thank you very much, and I'll take any questions.